This is Pascal Vranckx from Hasselt, Belgium at the ESC in London. We're going to discuss today the use of mechanical circulatory support in cardiology. With me are two experts in the field, Pascal Leprince from Paris in France and Christian Hassager from Copenhagen in Denmark. Christian, should we use mechanical circulatory support more often?
I think we should. We have to use it a lot more. I think one of the most important things to notice is that if you have acute coronary syndromes today, the patients who die with that disease, they die because of cardiogenic shock. So that's why this is extremely important. They don't die due to other reasons anymore. We've taken care of that. And then you could argue, should every hospital have a full-blown program? I don't think that's realistic, but I think we have to say that all hospitals that takes care of these patients should be part of a network taking care of that together with other hospitals, and they should have pre-written down procedures of how to handle these patients so that you don't, every time you see these patients, stand there and discuss should we or should we not scale the therapy.
Okay, Pascal, how to set up a program for mechanical circulatory support in an institution? How do you do it?
Well, the problem is that more you want to use it, more you want to implant early patient, less severe patient, almost prophylactically, more you need expertise. And if you want expertise, you have to get volume. So this is why, maybe not in every single center, because then otherwise it's going to be a mess, definitely. So better to get, I would say, center with high expertise level, reference center, collaborating with primary care center, for instance. Of course, you can have a small device, easy to implant in small center, but then implanting a device is not for implantation, it's to take care of the patient. And taking care of those patients is a long way to go. So you need to get reference center, and those reference centers have to build up the program, to set up the program and to collaborate with primary care center. I think this is the best way to go. This is the way we organize in our center, and I think this is a nice way to go.
And how to set up within an institution? Who do you need?
You need a cardiac surgeon, of course. You need an interventional cardiologist. And this is collaboration of both this guy who is going to make the collaboration to work. Of course, you need intensivists because they will take care of the patient. You need anesthesiologist, and you need the whole team. So I think it's not the debate of cardiologists, surgeon, and so on. All together, like for the TAVIs, for instance, all together we work for the good of the patient.
Christian, the lack of data in this field is notable. How do we have to proceed? What do we need in research?
It's extremely difficult to do research in these patients because they suddenly appear and there's not a lot of them. But when they're there, we have to be able to randomize the patients, and we need trials with hard endpoints. This is very difficult to do. We're currently trying to run a trial in Denmark with a device in cardiogenic shock, randomized, and the endpoint has to be mortality. We cannot rely on cardiac power or some other index. We need hard endpoints, and actually I think we are right now in a position where we should work together to do these trials, and the basic for doing these trials is to have these excellent centers first, and then do the trials. I think we all trust, it seems so intuitively correct to put a person on a circulatory support if the circulation is absent. But the cutoff for when we should do that is very difficult to define. As you said, we would like to move in a little earlier than when the patient is completely in a crash state. But how do we define that? We need clinical trials with hard endpoints, and we cannot do that as a single institution. We need to collaborate large centers around Europe, around the world.
Pascal.
Just one thing more about that. We need to define what is a cardiogenic shock. We talked about that earlier. What is a cardiogenic shock? What is the pre-shock? There is no definition right now. How do you want to get a trial without definition? So ESC and other society have to work on that, find a consensus on definition of cardiogenic shock.
Pascal, is cardiogenic shock the only indication? What other indications might exist for use of this device, and which device in which indication?
So, just to make it short, light cardiogenic shock. You can go for a temporary LVAD, percutaneous LVAD, CP. I would not go for the 2.5 impella, but the CP, or even the tandem heart in US, the one who's going from thoratec as well. Then if the patient is in a very severe cardiogenic shock, you are not going to make any miracle with those LVAD. You need a full circulatory support. So until now, ECMO is the best. So we have to work to make ECMO even more efficient with less adverse events. You need to implant an ECMO with a balloon pump to unload the left ventricle. It works. We have strong data on that already, that balloon pump plus ECMO does work pretty well. And it works for cardiogenic shock. It works as well for septic shock. We have a pretty nice experience on that as well. Septic shock, you can really save the patient in septic shock by using an ECMO. And you have the other part, VV ECMO for the lung shock, LDS. So ECMO is the kind of forward device for cardiogenic shock and lung shock.
So what do we learn today? We learned there are different types of devices for supporting the patients mechanically. The use of this type of device is not intuitive. We need some hard data to support our acts in cardiology. But what is particularly important in this field is teamwork. Teamwork within the institution, interdisciplinary, but also teamwork between hospitals to create networks in a sense that we can concentrate expertise and we can also afford this new technology. This was Pascal Vranckx together with Pascal Leprince and Christian Hassager from London, ESC.